Let's talk about something simple but clinically powerful: post-void residual urine, or PVR. Post-void residual urine means the amount of urine left in the bladder after you finish urinating. It tells us how efficiently the bladder empties. Normally, after we void, the bladder contracts and pushes out almost all the urine, leaving behind just a few drops. In a healthy adult, that residual volume is less than 50 milliliters. In older adults, up to 100 milliliters can still be normal. But if it's more than 200 milliliters, it suggests incomplete emptying. And if it's over 400, it means the bladder is in retention. So how do we measure it? The easiest way is the ultrasound bladder scan. It's quick, non-invasive, and accurate within about 10 to 15%. The gold standard is catheterization, where a sterile tube is inserted right after urination to measure the exact volume left inside. But remember, it must be done within 5 to 10 minutes of voiding. Otherwise, the bladder starts filling again and the results become inaccurate. Now, why does this happen? Normally, urination requires perfect coordination between the detrusor muscle that squeezes the bladder and the sphincters that control the outlet. When this coordination fails, urine remains inside. The causes can be grouped easily: obstructive, like prostate enlargement, urethral stricture, or a pelvic mass blocking the flow; neurogenic, nerve problems from diabetes, spinal cord injury, or multiple sclerosis; weak bladder muscle, seen in aging or chronic overdistension; functional or drug-related causes like anticholinergics, opioids, or tricyclic antidepressants. When residual urine stays high for a long time, it becomes dangerous. Stagnant urine breeds bacteria, leading to recurrent urinary tract infections. Mineral deposits form bladder stones. Back pressure damages the kidneys, causing hydronephrosis and eventually renal failure. Common symptoms include difficulty starting urination, straining, a weak stream, a feeling of incomplete emptying, and dribbling after urination. Some patients have urgency, frequency, or even overflow incontinence, where the bladder leaks because it's too full. To evaluate such patients, we measure PVR and perform supporting tests like uroflowmetry to check flow rate, ultrasound KUB for hydronephrosis or stones, and serum creatinine to assess kidney health. Treatment always depends on the cause. If it's prostate related, use alpha blockers like tamsulosin 0. Alfuzosin 10 mg daily. For large prostates, add finasteride 5 mg daily. If medicines fail, perform TURP or transurethral resection of the prostate. If it's nerve or muscle weakness, use clean intermittent catheterization to empty the bladder. Drugs like bethanechol 10 to 25 mg 3 times daily may help in mild cases. And if medications are the cause, simply stop or switch them. Behavioral steps like timed voiding or double voiding, urinating, waiting a few seconds, then urinating again also help. Here are a few quick pearls to remember. Always measure PVR within 10 minutes of voiding. A single high value is not diagnostic. Always repeat it. In elderly diabetics, even moderate PVR can signal nerve damage. And whenever you see overflow incontinence, always check PVR. So remember, post-void residual urine isn't just a number, it's a window into how your bladder and nerves are functioning. A simple scan that can detect obstruction, prevent infections, and even save the kidneys. This is Dr. Humanist, and I'll see you again with more stories where physiology meets practice and science connects to sense.